Hi, everyone. My name is Dr. Samantha, and I am the maternity mentor. Welcome back to another one of our live Q&A sessions that we have here every Monday at 9 p.m. Eastern Standard Time. This is a chance for you guys to ask your questions live. You can put them into the chat, and we will answer those questions for you, as well as answer any questions you may have submitted on the videos this week. Please remember to subscribe to the channel and to hit the notification button so you can get the latest notifications when we put out our new content. And we have a great video coming out tomorrow, actually. Remember, we're also on Facebook, Instagram, and Twitter. So share our channel and our pages with your friends and family. I'm going to go ahead and I'm going to get started right away. And I see that I have Flower in the chat who's asked a question. Can you please talk about the chance of breastfeeding with implants over the muscle and the lollipop lift? So this is a great question to start us off. I do have a video on breastfeeding after breast surgery, but it's really important to talk about this. I've been a lactation consultant for over a decade, so I've had to work with women who've had many different types of breast surgeries. Unfortunately, I think that plastic surgeons are not very clear on what exactly is going on when they do these procedures. So let's start. The first thing is an implant can either be over the muscle or behind the muscle. The muscle they're talking about is the chest wall. Now, most women opt for behind the muscle, which means that it's pushing the muscle forward, which pushes the breast forward, giving that larger appearance. Versus in front, you've got that breast implant right there inside the breast. The frontal ones are usually a little bit bigger in appearance, but they're also much more, you can feel them a lot more. Now, why does this matter? The breast ducts that fill with milk inside your breast, they need space to fill. Imagine it like little teeny tiny balloons inside your breast. So those ducts are flat, and when they fill with milk, they kind of, expand like a balloon, which means they need space. And when we're trying to dry out milk, one of the things we tell women to do is actually to wear a firm bra because it pushes against the breast, which limits the amount of space here. If the milk ducts can't fill with milk, they're going to produce less milk because it's all about supply and demand. So when you have an implant inside the breast, it's taking up a lot of the room that's there, and it's putting pressure on the milk ducts so they can't fill as much as they normally would fill. So this can actually impact your milk supply. Now, that being said, that does not prohibit you from breastfeeding. It simply means that you may have to do a little bit of extra stimulation and a little bit of extra work up front to get your milk supply established. You also may need to have a little bit more stimulation to maintain your milk supply if you are going back to work. What do I mean by this? Pumping. Mostly you might have to get some extra pumping in there depending on how well your baby latches. But women do successfully breastfeed even with an implant in the front part of the breast, in front of the chest muscle. Now, the lollipop lift has to do with the incisions that are made to lift the breast up and give it like a more like a tighter, youthful appearance. The biggest thing with any implant surgery, lifts, any of it, is whether you have a peri-areola incision. So the areola is the larger colored part of your breast, and the nipple's in the center of that. So most breast surgeries, they need to move that areola. Now, when you have an implant behind the muscle, that's one of the few exceptions that sometimes they won't touch the nipple or the areola. But in most cases, they're going to do some kind of incision because they want to move the areola up. And in some surgeries, they will actually detach the areola completely and then reattach it when they're done. Any areola incisions cut milk ducts. So let me say that again. Any areola incisions cut milk ducts. You cannot see them. They are microscopic. Plastic surgeons will say they'll do minimally invasive techniques to help preserve breastfeeding ability. They do attempt to do this, but they cannot see the ducts. And unlike a lot of other parts of your body, every woman is born with a different set of ducts. Like there's no set number, and each of your breasts may have a different number of milk ducts. So there's no way for them to know exactly where they're placed or exactly what they're cutting. Now, just because you have an areolar incision does not mean you can't breastfeed. Our bodies are amazing. And the way I try to explain this to women is when you get fat, your body has extra stuff. Okay. Now, if you have extra fat on your arm, but you were 90 pounds and now you're 400 pounds, your arm doubles in size, right? Well, you have to have blood flow all the way out to your skin. Otherwise, your arm would fall off, right? So what does our body do? Our body builds blood vessels all the way up to the outside skin. Even though we get twice as big, we still are making blood vessels. Now, let's say on this same arm, I get a deep cut. It cuts the blood vessels. Those blood vessels will heal themselves back together and start working again. The same thing can happen with your breasts. So what we figured out is that if you've had any kind of areolar incisions as part of your breastfeeding, the longer you wait to try to breastfeed, the more successful you will probably be, because that time that's in between gives your body the chance to re-anastomosize or put together those milk ducts back together and heal so that you can breastfeed successfully. So, the biggest thing you need to know if you have any kind of breast surgery is that you want to get a good lactation consultant on board so that they can evaluate how much milk that you're making and how much milk your baby is transferring to help you establish a good supply. And, if you get that done, you very likely could breastfeed even exclusively if you wanted. So I hope that answered your question. I'm going to go ahead, and if any of you have any questions, please feel free to, ask them in the chat. But otherwise, I'm going to go ahead and keep going with some of these questions that we got in. So we actually got a lot of questions this week on antibiotics, and I love antibiotic questions. So one of the biggest risk factors for having preterm birth, stillbirth, miscarriage, and complications during pregnancy is actually infection. And some infections that we get during pregnancy that are very common, like a urinary tract infection, those are very common for women. And most of the time, these urinary tract infections really aren't that big of a deal for us. But for a pregnant woman, this can be huge. Urinary tract infections, I cannot tell you how many times I saw women in preterm birth because of a urinary tract infection. So when you're pregnant, if you've been diagnosed with an infection, there's two different types you could get. You could get bacterial or viral. Viral infections do not respond to antibiotics, but bacterial infections do. And if your healthcare provider has deemed that you have a bacterial infection that needs antibiotics, I urge you to take those antibiotics. Urinary tract infections, again, are a great example. You really can't treat a urinary tract infection homeopathically. It just doesn't work like that. Once the bacteria is established, that bacteria is going to stay there and grow and grow and grow. And if left untreated, urinary tract infections can lead to kidney infections, which can lead to sepsis. So one of the things you need to really understand is that this seemingly small, not important infection can turn into a life-threatening illness for you and your baby. So we often give antibiotics for that and other things. Now, once your healthcare provider has prescribed an antibiotic to you and you've chosen to take it, you need to take all of the antibiotic, not just a couple pills. What happens with an antibiotic is they work so good. And so like within 24 hours, you feel so much better. Moms are always hesitant to take medication when they're pregnant. So they start to feel better. And then they're like, oh, well, I guess I don't need those anymore. And they stop taking them. But the thing is that bacteria is not all dead. It killed off some of it, but there's still some sitting there lying in dormant. And those bacteria that are left are going to keep multiplying. They're going to keep making more. And on top of it, they figured out what antibiotic we wanted to use. So they build a defense against that. So once they build this defense, if we try to use that same antibiotic again, it's not going to work. And then your healthcare provider is going to be stuck having to prescribe something stronger. And the stronger the antibiotics get, the more risk they are to you and to baby. So that's why it's so important that you go ahead and you take all the antibiotics as prescribed once you start them. You're welcome, Flower. So now what do we need to find out? Are the antibiotics safe? So let's start with a couple of our questions. I don't know if I'm pregnant. About 2 weeks ago, I took the infection medication, metronidazole, ketoconazole, doxycycline, and prednisolone. Later, I saw small, thick blood. Sorry. I'm hoping it's not a harm to the baby. So this particular person sounds like she was very sick. So she was given metronidazole, which is an antibiotic, and it is safe for use during pregnancy. Metronidazole is used for a variety of different infections, and it's extremely effective and very commonly used. Ketoconazole, that's actually an antifungal. So we also get fungal infections like yeast infections when we are pregnant. Our microbiome changes a lot, so I oftentimes recommend that women take a probiotic to help balance the gut, which can help prevent some of these infections. Ketoconazole is one of these medications that it's a risk versus benefit thing. So there are risks with ketoconazole. There are some studies that show that at way higher doses than we give a human being, in animal studies, they found some birth defects were noted. They've also figured out that it is not recommended in the first trimester, especially if you're carrying a male baby. So ketoconazole has a chance of affecting the androgens or the male hormones of a male fetus. So we want to try to avoid it in the first trimester whenever possible. Doxycycline. Doxycycline is a no, unfortunately. So doxycycline is an antibiotic. It's very effective. And normally for us adults who are not pregnant, it's a very safe antibiotic, very well tolerated. It's great. However, we have learned that doxycycline can cause some birth defects. Very specifically, it can cause malformation of bones, and it can also cause discoloration of teeth. And this seems funny because the teeth aren't, out when the baby comes out. So how is it? It's discoloring the teeth while the teeth are still underneath your baby's gums, and it can be a permanent discoloration. And then finally, prednisolone. So prednisolone is a medication. It's a steroid. So this is often used to help calm down a really bad infection. Prednisolone is one of these things that we want to do a risk versus benefits. Oftentimes, this is being used when you're extremely sick. Maybe you're having some respiratory issues. That means you're having trouble breathing. If you can't breathe right or you're super sick, it's not going to be good for the baby. So we really want to make sure we're using the right medications for you. However, prednisolone is not recommended in the first trimester. It has been known it's been known to cause an increased risk of cleft lip and cleft palate. So cleft lip is where the lip here doesn't fully close, and it'll be open at birth, or some of it may be missing altogether. Cleft palate, the palate is the roof of your mouth, that can also be wide open. So unfortunately, a couple of these medications are not recommended. So what can you do? Okay. So this is really disheartening in a lot of ways, but as a woman who is potentially pregnant, there's a couple things you can do. First, you could take a pregnancy test or ask them to give you a pregnancy test before administering any medication. However, depending on your HCG levels, which is the human chorionic gonadotropin levels, those are the levels that measure whether you're pregnant or not. If those levels aren't high enough because you're very early on, the pregnancy might not be detected. The next thing you could do is you could simply say, I am of childbearing age and there is a chance that I could be pregnant. Can you prescribe medications that are safe for first trimester pregnancy? healthcare providers will take that into account and try to give you medications that might better fit the profile. So these are two things that you could potentially do to try to protect yourself. The next question was also about metronidazole. She said, my OBGYN prescribed metronidazole to take. Now I'm worried because this is one of the medications that hasn't been recommended. So metronidazole, if we can avoid it in the first trimester, we try to. There are some animal studies that have some different concerns, but nothing human-based. And metronidazole is extremely effective against a couple STDs, which is why we can use it. Next one was, I'm 13 weeks pregnant and I have a severe cough for 2 months. I was given Bromsol syrup and Oracef capsules. Are they safe? So this is a great question, and this highlights something that I like to talk to people about. So Oracef capsules is also an antibiotic called cefixime, Cefixime, in case I'm pronouncing it wrong. That antibiotic is safe for use during pregnancy. But the other medication mentioned in this question is Bromsol. And I am not familiar with this medication. It is not used where I am at. So what does this leave you guys to do? Because I get questions about medications all the time. And you guys come from all over the world. So where can you go? So one of the things that you can do is you can make sure that when you're talking to the healthcare provider that's prescribing to you, you say, what are the risks versus benefits? They should educate you on what those are. Second to that, you can go to your local pharmacist. So secondary to healthcare providers like myself, pharmacists are your next best expert on medication safety. They receive a lot of education on medication. I would dare to say more education than a lot of healthcare providers because they are giving it to you. They are dispensing that medication. So if you feel unsure about what's been prescribed to you, you can ask them if it's safe. The other thing is, in a lot of drugstores, there's a lot of medications that are over the counter that you can just pick up off the shelf and buy yourself. But you can't just assume because it's on a shelf that it's safe for your pregnancy. And I need you guys to understand that you cannot just buy anything when you're pregnant. Your pharmacist can also assist you with that safety data. You can come up and say, I see this cough syrup. Is it okay for me to take? And they can help you. Okay, so that's another place for you to go. But unfortunately, specifically for that one, I am not able to comment because it's not something that is used where I am at. So let's talk about bleeding. And for anybody who's popped in, please feel free to put any questions you have into the chat like Flower did, and we will get to them as soon as we see them. So we had some second trimester bleeding questions. First trimester, is up until 12 weeks. Second trimester is, where you start at 13 weeks pregnant. It's my 14th week of pregnancy. In my 12th week, I felt a water discharge, and since then I have been bleeding. The blood is brownish in color and a very little amount. The ultrasound says the baby is fine, but I don't know what to do. I am so anxious. Okay, so a water discharge, just so everybody knows, if you have a water discharge and you're not sure if it's your amniotic fluid leaking versus you peed on yourself, and we can pee on ourselves when we're pregnant, you need to go and get that checked out immediately. Your water breaking is not a good thing, especially in the second trimester. This is a very worrying sign. If your baby does not have amniotic fluid, your baby's lungs cannot expand properly, and that can lead to a very poor outcome. Also, if your amniotic fluid breaks early, that can lead to infection. So we need to know right away if your amniotic fluid has, if your amniotic sac has ruptured and you're leaking fluid. Sometimes you can get a little teeny tiny tear, and then that tear will heal up. So you'll get a gush, and then it heals, and then you never have any more amniotic fluid leaking until the end of your pregnancy. Also, sometimes these little bursts of fluid can actually be discharged. So we want to see what's going on. Now, she also notes that she had blood that was brownish in color. So brown blood is old blood. This means something was bleeding and that bleeding has resolved. Well, you may hear that and think to yourself, oh, it's no big deal. It's resolved. You absolutely need to tell your healthcare provider if you see it, even if it's brown blood. Brown blood does not guarantee safety. It simply means something was bleeding and it is not bleeding right now. But that same something that was bleeding might start bleeding tomorrow. And if you go today and get checked out, they may be able to do something to prevent that. So brown blood is old blood, but you still want to have it looked at. Now, she got checked. She said the ultrasound says the baby is doing fine. Should I worry? She's worried. You know, if you have gone and done the due diligence, you've made sure that you don't have an infection, your bleeding has resolved, and now your ultrasound says the baby looks fine, the baby is probably fine. As we get through some of these questions, I'm going to explain why there's many reasons we sometimes bleed. So I'm 25 weeks pregnant. I'm kind of scared because today I faced a small amount of blood. I was vomiting in the morning and I saw 2 or 3 drops of blood. Now at night, I'm seeing on the tissue slight blood. There is no pain in my lower abdomen, but sometimes I feel heavy on my lower abdomen. I have an itching problem in my vagina. An ultrasonogram was done at 23 weeks of pregnancy. The baby was perfect and fine. It's a baby girl. Now I'm scared about this little bit of bleeding. Please suggest what I should do. Is this a matter of concern? Okay. So she highlights several things to talk about. When you vomit a lot, it puts a lot of strain on your belly. And if you're vomiting a lot, it can actually cause your abdominal muscles to feel like they've worked out. And that could be explaining some of that lower abdominal pain and pressure that she's having. It also pushes everything kind of down every time you're vomiting. With all that strain that vomiting causes on our body, it can actually cause you to burst little vessels. And the thing is, she mentions that she has an itching problem. So if you have a yeast infection or certain sexually transmitted diseases that can cause itching, these two things, what happens is it causes the vaginal tissue to be very thin and irritated. And then what can happen is that can bleed very easily or can tear and bleed very easily. So if she has, or if you are listening, you have a yeast infection that hasn't been treated, that can then, if you, any little bit like vomiting could cause it to tear open and bleed. The bleeding that you're describing doesn't sound terrible. 2 or 3 drops, a little bit on a tissue. I mean, I think that all is really good signs that this is a minor bleed. However, you need to tell your healthcare provider. You will hear me say this over and over and over. If you see blood, you need to tell your healthcare provider. Okay? That's what they're there for. Blood is the one thing you really cannot mess with. You can see bleeding for a variety of reasons, some of which are nothing and some of which are everything. So in this case, I think everything sounds okay, but you want to get it checked out. And you want to make sure that you have them check you for a yeast infection and sexually transmitted diseases. There's also a disease that you can get that's not sexually transmitted, and it's called bacterial vaginosis. So, or BV. So, BV is not a sexually transmitted disease. It's basically too much bacteria around the vagina and it causes an infection and it needs an antibiotic. And women can actually get BV from their partners. So, this is the one thing that you should know. This happens because your partner may not have very good hygiene. Especially if they're not circumcised. You know, men, when they're not circumcised, they need to pull back the foreskin to really clean. So if you are getting BV, it could be that it's your partner who just needs to maybe take a shower before you guys have sex, at least while you're pregnant, because your microbiome of your vagina is different while pregnant. But again, this can cause some of that itching and would need treatment. Let's keep going with bleeding because we do get a lot of these. So I've been spotting for 3 weeks. I had a scan at 6 weeks and everything looks good so far. Another one said bleeding at 8 weeks of pregnancy. Could this be normal? So there are many reasons why we could see bleeding that is normal. The hormones that you need to sustain your pregnancy also thin out the vaginal tissue. So when this happens and it's thinning out the vaginal tissue, it makes it easier to bleed for a variety of reasons. One, sex. Okay, so if your vagina is very thin and irritated and you have sex without lubrication, you're very likely going to bleed. Now, this doesn't mean that you can't have sex. It simply means that you need to use a lot of lubrication when you're pregnant. Another reason could be a subchorionic hemorrhage. And we have a couple questions that are coming up about that, but that's a little pool of blood underneath the placenta. You can also bleed if you have different positions of your placenta, like a placenta previa. So here's your uterus, here's your cervix, and a placenta previa is where the placenta forms over the cervix, so you can get some bleeding. You can also have implantation bleeding. This is when the baby, the fertilized egg, the baby comes down into the uterus and attaches to uterine wall. And at that moment, you can get a little bit of bleeding. You can also have your period. So many women will continue to have their period for 1, 2, 3 months into their pregnancy, and they'll have a perfectly healthy baby. So there are many reasons that you could continue to bleed. The most important thing is that you call your healthcare provider so they can assess you. So the last question about bleeding that we have, my HCG level dropped to 1356 now in the 8th week of pregnancy. I'm having a little spotting over the last 2 days. Is it possible to have a healthy pregnancy still? So, unfortunately, this sounds like a miscarriage. So, let me explain. HCG, again, is human chorionic gonadotropin. This is the hormone that we test when we have the home pregnancy test as well as in our blood. HCG should continue to rise over the course of your pregnancy. So when a woman comes into the hospital or into a doctor's office and we are suspecting a miscarriage because we see bleeding, one of the things we'll do is we'll draw her blood and we'll do an HCG level. And 2 days later, we ask her to come back and we draw more blood to do another HCG level. If that level is rising, that's a good sign that the pregnancy is continuing as planned. However, if the HCG level is dropping, that usually means that either an imminent miscarriage is about to happen or has already happened. One of the things that you should be aware of is if you are suspecting that you have a miscarriage, you are having a miscarriage, and you were to use a home pregnancy test, you're going to still test positive even for a couple days after you've had the miscarriage because that HCG level is still coming down. So an HCG positive pregnancy test does not mean anything if you've been told that you are having a miscarriage. And this is probably what's happening with this person is that the HCG level going down most likely means that you're having a miscarriage. So I'm really sorry to, say that to you. And I hope everything is as good as it can be for you and your family. For those of you who are joining us, please feel free to ask any questions you want into the chat. Answer them for you, okay? This week we had a couple of questions about hemorrhoids. Hemorrhoids are a big topic. Hello, ma'am. I'm 9 months pregnant, having hemorrhoids, 2 lumps out of the anus. They are not going when I push them back. I don't have a serious problem due to this, but I am worried about a vaginal birth. What should I do? Do I need to consult a doctor? Is it curable without surgery? Please reply. The other one says, I am 25 weeks pregnant. Now I can see an anal skin tag. I am worried as it also affects bowel movements. Please give me some suggestions. So hemorrhoids are basically an enlarged blood vessel. So you have a lot of blood vessels and nerves at the anus. This is where we go poop, and you need it so that you have proper bowel control. What happens during pregnancy is a lot of women get constipated. This happens for a variety of reasons. Women tend to not drink enough water. They tend to not walk around as much. And then you got this big old baby that pushes on everything and slows everything down. And so you get constipated. And when you're constipated, it's very hard to go poop. And so you end up pushing and straining. So when you're pushing and straining, that causes those blood vessels to expand and they get bigger, and that causes a hemorrhoid. Once a hemorrhoid has formed, it does not go away. It's there. until you decide to fix it surgically. Now, there are some medications that can help it shrink and get smaller. Some of those include like Anusol, which is like a hemorrhoid cream, as well as Tux pads, which are little cotton pads that have witch hazel in them. And you lay that on top of an external hemorrhoid. Those are the ones you see on the outside. And it can help shrink the tissue. You can actually have internal and external hemorrhoids. Now, the one question with the skin tag, if you have a skin tag that would be cosmetic, that would have to be removed, surgically. Now, as far as having a baby vaginally, so you can have a vaginal birth with hemorrhoids. In fact, hemorrhoids can be caused by vaginal birth. Sorry about that, ladies who don't have a hemorrhoid yet. During the pushing process of giving birth, you can actually develop hemorrhoids. So you can deliver safely. The only reason why you wouldn't be able to deliver is if your hemorrhoids are actively bleeding, if you've developed an anal fissure, which is like a large anal cut, and it's large enough that they're concerned you might tear from that, or if you have some kind of infection due to these, things going on. But otherwise, you can have a vaginal birth, but your hemorrhoids might get worse. So what can you do? The biggest thing is to try to prevent constipation and make sure you're going regularly. The way you can work on this, you can use Colace, which is a stool softener. Make sure you don't use any laxatives. Let me repeat that. No laxatives. Laxatives can cause preterm birth. No laxatives. But you can use stool softeners. The whole point of a stool softener is it gathers water into the colon to make the stool soft so you don't have to strain. You can also use different types of homeopathic stuff, specifically in food. So the foods that help us go to the bathroom better. Fiber is one. A very popular one is prunes or prune juice. If you are diabetic, please do not use prune juice. It is full of sugar. Even if it doesn't have any sugar added to it, it still has sugar in it, and you want to avoid that. You can also walk regularly as long as your doctor hasn't told you not to walk. So you can do all these things homeopathically to try to prevent the constipation getting worse and to help with those hemorrhoids. After you give birth, you can get the hemorrhoids fixed surgically. However, what I would tell any of you, if you're not sure if you're going to have any more babies, don't get them fixed right now. Okay, because you could just develop more and then you're having another hemorrhoid surgery after that. So you want to wait until you're all done with that. For those of you who are joining us, my name is Dr. Samantha. Hi, I'm the maternity mentor. We're here for one of our live Q&A sessions that we have every Monday at 9 p.m. Eastern Standard Time. We're here to answer your questions live, so please feel free to put anything into the chat. And we're also answering questions that you have submitted onto our videos this week. So I'm going to keep going. We've had some great questions so far. Let's talk about early signs of pregnancy. Is it possible to know if during your fertile period you get pregnant? Today was my final ovulation day. Range started this past Saturday. I feel very different than I ever had, and we are trying. I have this weird knot that is formed above my breast, and my breasts hurt. Worse than they ever had. I'm weirded out. Okay, so is it possible? You can't really detect a pregnancy like the day or two after you've gotten pregnant. Like from a physiological standpoint, the pregnancy tests aren't going to pick up. Part of the reason why the pregnancy test, you have to wait a little bit of time is that HCG level has to rise in your system. You oftentimes can't even see a baby on ultrasound until you're like 6 or 7 weeks pregnant. Sometimes you can at 5 weeks, but it's not always there. So the blood test isn't going to show anything. So really, honestly, the answer to the question is no, probably not. But there are so many women out there who are very intimately connected to their bodies, and they understand their body processes. And when something changes, they can feel it. Okay. And I say women, I'm actually going to clarify this and say there are so many human beings that are attached to their bodies. I fully incorporate into my practice. If one of my patients says, I know this about my body, I feel like this is what's wrong, I know that this is the place to do this. Like when I was drawing blood in the hospital, they'd tell me what vein, I'd go to that vein. Sure enough, I'd almost always get it. We know our bodies better than anybody else. We are sitting with them, we can feel them. And so I feel like when you listen to somebody, you usually get the right information from them. And so I tell you, if you listen to your body and your body's telling you something, it's probably there. Now, two things. First thing, you may end up not being pregnant. You may get your period and then you're going to be a little disappointed. I would not tell you that that means you weren't pregnant. We now know that there are so many women who have miscarriages, 1 in 6 right now, and that probably is going to change. And really, on top of that, there are miscarriages that are happening all the time where people never know they are pregnant. They never get a positive pregnancy test. They just go straight to their period because our bodies are designed to to get rid of pregnancies that would be bad for our health. If there's severe genetic abnormalities with a fertilized egg, our bodies are going to reject that because that egg is not going to come to fruition. It's going to cause a very dangerous pregnancy for us. And nature wants us to have pregnancies that will go to full term. So we're having miscarriages all the time and we don't know it. So if you feel like you are pregnant, you might have been, even if you get a negative pregnancy test. Now, the other thing is there's something called a psychosomatic pregnancy. This is where you wish you were pregnant, and so you get pregnancy symptoms. Now, the reason why I mention this is not to disappoint, not to discourage, but simply to say you need to acknowledge that this is possibly what's happening. That you're so excited and so not desperate, but you just want to be pregnant so much that you feel things in your body that may or may not be there, or they're there, but they don't really represent pregnancy. So just understand the reason why I say this is so that you have the possibility of not getting your hopes let down if you do get a negative pregnancy test. But I think that's a really good question. But technically speaking, there's no test to take. So another question that we got was about diabetes, looking for a holistic treatment for it, natural foods and herbs to help. So diabetes is the abnormal control of your blood. It's like your insulin does not work well, insulin resistance, so you don't absorb blood sugar the right way. So what's the best way to control diabetes? A low carbohydrate diet. I actually have on my channel a pregnancy superfoods and a keto video that we can link. Keto is my absolute favorite diet. I've done so much research about it. It's low carb, but it's not low carb where you're eating bad fatty foods. It's basically whole nutrient foods. And this is such a great diet for somebody that has gestational diabetes because what you're looking to do is to reduce the processed sugars, to reduce your overall carb load, but still eat healthy fats and healthy proteins. And even when you are eating carbs, the carbs are very healthy for you. For example, you get rid of most of the fruits that are really bad for you when you have diabetes, but you can still have stuff like berries, which have lots of antioxidants and other nutrients. So what I would tell you is the best thing to do is to eat a low carb diet and make sure you're talking to your healthcare provider to see if they want you to limit a certain amount of calories, because that's something that you need to pay attention to. Another question we got was, my first baby was 9 pounds, 5 ounces, delivered at 40 weeks, induction, and a vaginal birth. I did not have diabetes or any other conditions that, I did not have diabetes or any other condition that I was caused by this. I'm pregnant again and curious if it'll be likely that I'll have another large baby, if I should be concerned about a vaginal birth due to size, and if I were to hit 40 weeks again, wait it out for an induction, will that increase a larger baby? Okay. So, gestational diabetes does, if your sugar is not under control, it can cause a large baby. And that was a large baby. One of the reasons why we induce is to try to reduce the size of the baby that's going to come out. Every week after 36 weeks, you can be gaining a pound a week just in baby. And so like imagine that you can start with a 5-pound baby and end up with a 9-pound baby in 4 weeks. So, we don't want to deliver these large babies because there's risks like a shoulder dystocia, which is where the shoulder gets caught up in the pelvis, and this is a medical emergency and can actually result in the baby dying. So when we try to induce, when we expect that the baby's going to be large, this is because we are hoping to prevent those types of things. So if they're thinking that you're going to have another 9-pound baby, you should absolutely be induced, in my opinion, like 100%. Like, don't even question it. What you do want to do is try to see all of the natural ways you can induce your labor. We have a video on that we'll link into the description. But ask your doctor, can you start pumping early? Pumping your breasts will actually cause some uterine contractions, which can help ripen your cervix. Ask them if you can use stuff like rosemary, primrose oil, on the cervix. Ask them if you can use an exercise ball. Make sure you're eating right and drinking right. Make sure you ask if you can use Cervidil. Cervidil is a type of medication that instead of just starting with oxytocin and doing contractions, it's like a little flat tampon-like thing that has this medication in it. We slide it up next to the cervix, and the whole point of it is to soften the cervix so that when you do get something like Pitocin, the cervix just opens right up so that you can have the baby. So you want to ask them for all of this stuff, like everything you can to make sure that you have a successful induction. But I would absolutely be doing that. I would also 100% be delivering in a hospital. Okay. In a hospital, we can do a cesarean section delivery. And I will tell you that I have worked with many holistic providers, OBGYNs, not even midwives, who will do all sorts of very natural things during births to have a fantastic experience, including hypnobirthing, including water births, the whole 9 yards. So just because you're in a hospital does not mean it will be this horrible medical procedure. It just depends on the healthcare provider you're working with. But if you are going to have a very large baby, there is a risk that you will need a C-section, and you want to be in the right place to have that immediately. We have a question about cerclages. So cerclages, for how long should I stay without having sex after a cervical cerclage? So let me tell you guys what a cerclage is. A cerclage is a stitch that we put into the cervix for preterm birth. So you got a uterus, at the bottom is the cervix, okay? So the cervix should be long, thick, and closed, okay? Now, cervixes aren't completely closed. They're not sealed closed. They're actually this tiny crack open. And what happens is during pregnancy, this gets filled with like a mucus plug. That's when you ever hear about the mucus plug dropping. What people are talking about is when they start to dilate, the mucus plug comes out. Okay, so that's what they're talking about. And that mucus plug helps prevent bacteria and stuff from going into the uterus and causing an infection. Now, when you're in preterm labor, or if you're having cervical insufficiency, that means your cervix isn't working right. What that actually is looking like is the cervix, which is supposed to be closed, is starting to open. And we need to stop that, because if your cervix opens too far, for example, 5 centimeters, and you're 16 weeks pregnant, the baby can come out. Okay. A lot of people don't realize that. They hear 10 centimeters and they assume that no matter what, somebody has to be 10 centimeters to deliver a baby. But unfortunately, when you're earlier in your pregnancy, you can be dilated only halfway and you can deliver a baby without even pushing, which is why it's so important for us to prevent preterm birth. So a cerclage, what we do is we go in, if we have enough cervix, if the cervix is still long enough, we go in and we sew it shut. So just like what you imagine, a needle and some sterile surgical thread, and they basically sew it shut. And that helps keep that closed until you get to full term. Usually around 36 to 37 weeks, your doctor will go in there and they'll snip the thread, and they'll pull out the thread, and then that allows the cervix to open up. And then whenever you have the baby, you have the baby. If you were to go into preterm birth and we started to see bleeding, we would also go in there and snip that open. Because if we don't, that could end up leading to some serious complications. Okay. So now, as far as the question, how long after you get a cerclage can you have sex? You need to ask your healthcare provider for sure. But most of the time, we recommend no sex, nothing in the vagina. Your body started to reject your pregnancy, and as a result, your cervix was dilating. So, sex is going to be contraindicated in this sense. We do not want anything in there or anything disrupting that. This is something where at this point you're on pelvic rest until you deliver, unless your healthcare provider tells you otherwise. For those of you who have joined us, thank you so much for coming in. Please feel free to put any of your questions into the chat. So premature birth. I just returned from my 20-week anatomy scan, and my cervix is measuring 2.5 centimeters. They sent me home for another 4 weeks, but I feel like something is wrong. What should I do? This is my first baby. So one of the things that I wanted to mention with this one is if your gut tells you something is wrong, you always want to pursue that, get it checked out. Keep advocating for yourself. However, 2.5 centimeters of a cervix is not necessarily a bad thing. So usually cervixes, I would say we look for about 3 to 4 centimeters, but everybody's a little different. What would worry me more is if you had a cervical length of 4 and now your cervical length is 2.5 versus just getting your first measurement at 2.5. If that's all that you got, it could be just you. We're not textbooks. Everybody's body is a little bit different, and everybody, their pregnancies go a little bit differently. So I would tell you that right now, everything sounds good to me. Getting checked out again in 4 weeks sounds good. But any symptom, cramping, lower back pain, bleeding, spotting, your abdomen hurts, go to the doctor to get checked out. Okay. But otherwise right now, everything sounds pretty good. Okay. RH factor. I was 9 weeks pregnant when I started bleeding. I was rushed to the hospital and they found the baby's heartbeat was missing. It was a miscarriage. I am RH negative. The doctor recommended Rogam. Should I take this injection now or in my next pregnancy? You should take this now. Okay. And if you haven't taken it, you can get it from your OBGYN's office. Okay. So RH negative, rhesus factor. This has to do with our blood type. So there's 4 different blood types, O, A, B, and AB. And then attached to that is a positive or a negative, and that's the RH factor. Now, when we are RH negative, if we get pregnant with an RH positive baby, and that can happen because the dad could be RH positive, that creates this blood incompatibility. And what we now know is that your baby's cells cross the placenta and come into your circulation, right? And so what happens is when your baby's positive blood type gets into your circulation, your body recognizes that as a foreign invader. And it goes ahead and the immune system starts creating this response because it wants to attack those cells. Well, your immune system can attack the baby itself as a result. And this can lead to miscarriage. Now, what happens is the way to prevent this is to create like a response that blocks that, right? And we do that with Rogam. Rogam helps protect us. If you have any miscarriages and you're RH negative, you need to receive the Rogam shot every single time. We give the Rogam shot at 27 weeks pregnant, approximately, in case you have the baby early to prevent any issues. And then once you deliver your baby, we test your baby's blood type. If your baby is also negative, you don't need Rogam. If your baby's blood type is positive, you will need another shot. So after this miscarriage, I would absolutely get that. That will help prevent complications in a future pregnancy. Subchorionic hemorrhage. I'm 11 weeks pregnant with a 1.25 cc perisac fluid. Light spotting is there. Is that harmful to my baby? Is it normal to develop a subchorionic hemorrhage during the 28th week of pregnancy? So, subchorionic hemorrhage is a little tiny area of blood, like a pooling of blood underneath the placenta. So the placenta is the organ that feeds your baby. It attaches to the uterine wall. And when it attaches, there's all sorts of blood vessels here. And so sometimes you'll get a little pool of blood because maybe one of them bursts a little bit. It's just tiny. This can cause some spotting. Okay. Now, subchorionic hemorrhages happen all the time. They're extremely common. A lot of times you'll have absolutely no symptoms ever. They're found on ultrasound and they go away. It just happens and they disappear. Some of them will maintain themselves through the entire pregnancy and there's no issues whatsoever. So could you develop one? Yes. Do we know why? Not necessarily. Is a 1.25 cc up too big, too small? Honestly, it just depends on the size of the placenta. Usually when you start out, they're bigger because the placenta is smaller, and then the placenta gets bigger and the subchorionic hemorrhage gets smaller, and sometimes they resolve. That means they go away. Subchorionic hemorrhages are not necessarily a big deal. All that you need to know is that you listen to your healthcare provider's advice. If they're telling you to rest, you rest. If they're telling you to act as normal, you act as normal. It's very important. That's the biggest thing. But there's nothing to do. They happen all the time. And I would just, you continue on as you have been. TDAP. I got my TDAP shot at 20 weeks. Was it too early? So TDAP is tetanus, diphtheria, and pertussis, okay? It's a shot that we recommend to pregnant women, and we also recommend to any caregivers of the baby. Why are we recommending this shot? One of the things it's protecting from is pertussis. Pertussis is whooping cough. Whooping cough is endemic in the United States as well as many other parts of the world. I'm down in South Florida, and in Miami-Dade, we have a lot of cases of whooping cough. And whooping cough has actually killed babies in our community. That's how serious it is. Now, a lot of people say, well, if I get a cough, I'll just protect myself from the baby. It's not how it works. Pertussis or whooping cough in adults can be asymptomatic. What does that mean? That means no symptoms. You can walk around with whooping cough as an adult and have no symptoms whatsoever. You don't even know you're sick. But your baby can develop a life-threatening cough that prevents them from breathing, causes respiratory issues, and they can pass away. It's very serious. Most labor and delivery, mother, baby, pediatric, and NICU nurses are required to get the TDAP vaccine in order to work in the hospitals because we're working with these children and we need to make sure we protect them from us. Now, why can't we just vaccinate your baby, you say, right? Because that would make sense. Let's just do the baby. Pertussis is a live vaccine. Your baby can't get it right away. So as a result, the only way we can protect the baby is to protect you instead. That's the biggest defense we have. So we recommend it for moms because mom is the one who's going to be taking care of the baby the most traditionally. And so we want her protected right away. We also recommend that dads, partners, best friends, grandma and grandpas, aunties, nannies, whoever is going to be with this baby a lot, they're the ones who are also getting this to protect themselves. We recommend this vaccine between 27 and 36 weeks pregnancy, but the earlier is the better. So 27 is generally when we want you to get it. This person got it at 20. Is that a bad thing? No. Is it when we recommend it? Not necessarily. Part of the reason for the recommendation is that we know that the vaccine will last for at least 18 months strong. So, if we get you about halfway through your pregnancy, then we're hopefully getting the baby covered through age 1 for sure, when the baby is going to be able to have gotten that vaccine themselves. But it is okay that you got it at 20 weeks and you're not going to be able to get it repeated anyway. But definitely encourage your family to get that. We got a umbilical cord question this week, which was great. I was diagnosed with marginal cord insertion at 20 weeks ultrasound. Could you speak on the risks of the development to the baby and the birth that could come from this and the severity of the diagnosis? So marginal cord. So your placenta is kind of like a circle. Everybody's placenta is a little bit different. And generally speaking, believe it or not, most placentas, like 99%, your cord is right in the middle. Okay. It's right in the dead center. Just a little bit off. That's just how it's meant to be. Okay. And it's on the other side of your placenta, on the back side that attaches to the wall, you'll see it branches out with a whole bunch of blood vessels. A marginal cord insertion is, instead of having it in the center, your umbilical cord is off to the side. It's close to the edge. It actually needs to be about 2 centimeters from the edge or less, and that's considered marginal cord. Now, what does that mean? That means that there is risks that the baby might not develop as well because the blood flow may not be as good to the baby. There's also a risk that if you were to have a uterine rupture right there, not a uterine rupture, I apologize, a placental abruption, which is where the placenta starts to tear off. If it happened right here at that cord insertion, that would be a very serious life-threatening emergency to the baby, like immediately. So, the biggest thing is blood flow to the baby, which can restrict growth and can restrict nutrients coming to the baby. But that's actually not a guarantee. A lot of babies actually will develop completely normally and they will have no issues whatsoever. The severity of the diagnosis, honestly, could change over the course of the pregnancy. So you want to make sure that you're being followed closely. This is a pregnancy that I would recommend maternal fetal medicine stay on top of so you can get multiple ultrasounds over the course of the pregnancy. One of the things they do with those ultrasounds is they'll do Doppler flow or Doppler studies. This is where they can actually trace how much blood is going back and forth across this cord. And they can also check to make sure baby's growing well. So that's the biggest thing with this is to monitor the baby. Hey, Tess, I see your question. Should dads get TDAP for every new baby as well, or does getting it once cover multiple years? It does cover multiple years. They seem to be it seems to be changing regularly now. It used to be that it was every 5 years that you could get it. I've heard some people saying even every 3 years. So, but you definitely can get coverage for more than just 1 year, let's say, if the babies are apart. As nurses, we can get it every 5 years. So it's not something that you're going to need to do every single time you get pregnant. But I would also tell you as we all know, since COVID came around, vaccines are constantly changing. Vaccine regulations are constantly changing. For many of you, you may or may not have heard there's actually a new vaccine out, and I'm going to be doing a video on it. It's the RSV vaccine that pregnant women can now get in order to prevent RSV virus in their babies. So as you can see, everything is constantly kind of advancing and changing. But as of right now, no, you do not need to get one every single baby. It's about every 3 to 5 years. So that's a good question. Thanks, Tess. All right. So let's see. We got a question on urinary tract infections. We talked a little bit about those earlier. They are very serious. You need to take them seriously. This question was, I have a UTI. I'm 7 months pregnant. My doctor gave me amoxicillin. Is it safe for me? She wants me to take it for 5 days. Absolutely. Amoxicillin is one of the oldest antibiotics we use. It is safe for pregnancy. Make sure you take all of it. Remember what I said. Do not take part of your prescription, and when you feel better, stop. You take all of the medication as prescribed. Couple more questions. We got a couple questions this week on yeast infections. And they, yeast infections are very common. So I'm 8 weeks pregnant and I'm experiencing vaginal discharge. Please tell me, can I treat this at home and what should I do? I'm 34 weeks pregnant and my provider has prescribed diflucan. I've gotten yeast infections back to back throughout the entire pregnancy and also BV. I actually have both right now. I'm nervous to take the diflucan because of everything I've read, and it's highly discouraged during pregnancy. I'm currently 22 weeks pregnant, and my doctor prescribed me with fluconazole. You mentioned that this has been linked to birth defects. Should I trust my OB? I'm very scared. My discharge is watery, and often there's no smell or thickness. I wipe myself often, which I believe has caused me to be irritated. Do you believe I have a rash or a yeast infection? So let me clarify with diflucan. Diflucan is linked with birth defects or potential birth defects in the first trimester. Once you get into the second trimester, it is an extremely effective treatment for yeast infections. And I have seen preterm birth with yeast infections. Okay. So it's important to treat yeast infections aggressively before they turn into something worse. However, before you take diflucan, you want them to verify you have a yeast infection. So there's a lot of discharge that can come out of a vagina when you're pregnant. Some of it's normal and some of it is not normal. The one question also mentioned BV, as we talked about earlier, that's bacterial vaginosis. That is a bacterial infection, not a yeast infection. That needs to be treated with antibiotics. So how do we figure out which is which? You need to go to your healthcare provider and we swab it and send it to a lab. So swab, long stick with a sterile cotton swab on the end. We will lay you back and use a speculum to open up the vagina so that we can see the cervix. And once we see the cervix, we put that swab in and we gently rub to get some of that discharge onto the swab. We put it on like a dish and we send it to a lab to be looked at. Okay, what can they find from that? They can tell if it's normal, like mucus. They can tell if it's sperm. They can tell if it's amniotic fluid. They can tell if it's bacterial, viral, yeast, fungus. They can tell if it's a sexually transmitted disease, and then they can identify specifically what it is. In a lot of cases, we can also tell you whether or not what antibiotic, for example, can be used. So you want to make sure that what you're dealing with is yeast before you take diflucan. Now, if it's your first yeast infection during your pregnancy, there's a lot of safe over-the-counter products that can be used. Ask your healthcare provider if you can use them. If they're saying no, understand diflucan is usually a single dose, maybe 2 or 3 doses. And if you're into your second or third trimester, you are probably going to be fine. Most of the development where birth defects can happen is in the first trimester. And again, it's very important to treat a yeast infection because if left untreated, they can lead to preterm birth and miscarriage. So I would absolutely, if you need to use them, you need to use them in order to help prevent. And again, I had another question about discharge for a woman who is 6 months pregnant. The same thing applies. We need you to go in and get checked out so we can see what is causing that discharge. Hi, Jessica. How long should it take to recover after birth? After a vaginal birth is what I'm going to assume, to heal down there. 3 weeks post-pregnancy, bloated baby belly advice. Okay, so it will, generally speaking, take 6 weeks for any types of tears to recover, as well as for your uterus to get back down to normal size and for the bleeding to stop. Bloated baby belly, it just depends. Everybody's a little different, but usually you will start to see most of that go away by week 2 to 3. And then by week 6, it should be significantly down. The one exception to a bloated baby belly is if you have a hernia or a diastasis rectus, which is the separation of the abdominal wall. And we actually have a video on that. We'll try to link into the description. So if you developed a hernia, or if a hernia got worse, a hernia is where the stomach, the abdomen wall kind of actually opens up underneath the skin. And as a result, you'll actually look like your belly is popping out more, but not in the same way a pregnancy belly looks like. So you want to make sure that you are getting that checked out, because that could be what's going on. You want to get that checked out. And then the other thing you can do is, as far as your healing goes, you may end up having some pain and stuff for the next little bit of time, and that can be normal. Yes, Jessica, that could absolutely make him that could actually make the baby vomit for sure. If he is vomiting a lot, you want to go ahead and you want to make sure that you call your healthcare provider, because little babies shouldn't be vomiting a lot. If it's a hernia, they're most likely not going to do anything for it right now. They would go ahead and they would monitor it, and usually they fix those hernias when the baby's a little bit older. They don't want to usually do surgery on a 3-month-old baby. It is usually a surgery. Oftentimes it's a little minor surgery. It's like nothing. They put in a little mesh to close it up, but they're not going to do that right now. They're going to do it when he's older. So, I'm going to finish up here. If you guys have any last questions, please put them into the chat. And actually what I'm going to finish up with is a question that I got, or a comment that I got on hyperemesis. So I'm so tired of folks downplaying this illness. I almost died and nobody listened to me. I was so hungry, pretty much almost starved to death, vomiting acids right through the day because my stomach was empty. Saying it was nausea is not true. In 2023, they can do so much better in researching to help women that suffer through this. It's not normal to feel like this when you're dying when you're pregnant. So she's referring to hyperemesis gravidarum. And hyperemesis gravidarum is severe morning sickness. And it is a very serious illness. I actually had hyperemesis gravidarum myself with my 2 pregnancies. My first pregnancy, I was in the hospital for a week on IV fluids. That pregnancy, I lost about 25 pounds. I gained a little bit of that back. My second pregnancy, I actually never gained anything. I lost 30 pounds total. I went into preterm labor at 32 weeks pregnant because I vomited 8 to 10 times that day. I vomited straight up through the end of my pregnancy. It is not fun. It is not morning sickness, and it can cause PTSD for some women. I can tell you in particular, while I don't think I had PTSD, there was one particular food that I couldn't eat for a couple of years when I thought about it back to my hyperemesis days. So it's very, very traumatizing, and it is very miserable. And when you're trying to work and take care of kids and all sorts of other things, it is very, very challenging to deal with. So if you have friends and family that have hyperemesis gravidarum, please treat them with a lot of kindness. This is an illness that is not studied enough. There are some treatments you can do. There's Zofran and other things, but unfortunately, we still don't know a lot about it, and it's very challenging to deal with. Ooh, congratulations, Laura and Mike. I am so happy to hear you had a baby today. Hopefully it went well. Jessica, what's the difference between vomiting and spitting up? Usually it's amount. It's a lot more. You'll see almost spit ups like little bubbles of spit up, and you might see a little bit of dribble, might be a wet burp. Vomiting is like so much milk comes out that it almost looks like they're going to choke on what's coming out of their mouth. It's extremely different. Now, sometimes you'll have a very large spit up, but usually spitting up is very much associated with a feed. It's very much associated with a burp. It's usually within those 15 minutes after you feed. Vomiting will oftentimes happen immediately. It'll happen a long time after a feed, like all different types of things. So it really does, it changes a little bit. What I would tell you is if you're not sure if your baby is vomiting versus spitting up, you want to start by documenting. Write down every time the baby's doing X. Give your pediatrician data. I used to work with computer programming and stuff. I love data. I love my patients being data collectors. So what time did you feed the baby? How much did you feed the baby? If you're breastfeeding, it's, left breast, right breast for time. If you're formula feeding or breast milk in a bottle feeding, how many ounces? So when did you feed? How much did you feed? When did the baby spit up or vomit? Take a couple pictures. That's stuff that you can do to also document for your pediatrician. Those are ways for you to give them data so they can see. If you're telling them that the baby's like doing this large spit up every 2 hours, this is probably something that they need to look into more seriously. My baby's due date is September 8th. I watch a lot of your videos. I make exercise 4 hours after going into labor. Good job. Very good job. I really appreciate that. That's a very big compliment. Thank you so much, Laura and Mike. So I'm going to finish up for tonight. My name is Dr. Samantha, and I am the maternity mentor. You can see us here every Monday at 9 p.m. Eastern Standard Time to answer your questions live, like we see, to also answer any questions that you've submitted on our videos. Please share our channel with your friends and family. Follow us on Facebook, Instagram, and Twitter for additional content. Subscribe to my channel. It really, really, really helps me out. I really appreciate it. And please also hit the notification button so you can get notified of our latest videos. I'll give you a sneak peek. Tomorrow, we have a video coming out on the top 10 baby products you should buy that a lot of people don't think about buying. Okay, we did a 10 worst products that are a waste of your money. Now we're doing the 10 best products you may or may not have thought about. So that's coming out tomorrow for you guys. So that's why you want to subscribe and hit the notification button. If you guys have any questions or anything, feel free to join us next week. I'm going to say goodbye for now. I am Dr. Samantha, the maternity mentor. Have a great night.